Greetings, everyone. I'm Dr. Amit Pandey, and on the occasion of World Glaucoma Week 2025, I'll be talking about surgical management of glaucoma. I thank Young Ophthalmologist Society of India for this opportunity. I don't have any conflict of interest, so I'll be talking about why, when, and how surgery has to be done. Why, what are the benefits of surgery? What are the indications of surgery? That is, when to do surgery, and how, that is, with surgery, and how to do it. I've not included laser procedures in this presentation. Coming on to the first question of why, glaucoma, as we know, has a huge global impact on vision loss and blindness. More than 4.5 million people are blind due to glaucoma, one of the most common causes of irreversible blindness in the world. And in India, out of those 4.5 million blind people worldwide, 1.5 million are in India. So, what are the benefits of surgery? uh, you get a more stable intraocular pressure without medications or with lesser medications. You have a lesser visual field loss progression. You have lesser adherence and compliance issues, lesser ocular surface disorders, and overall a better quality of life if the surgery is done well and surgery is working. So with surgeries, these are my preferences. Again, we have a lot of options available worldwide. And these are the surgeries that I do, from minimally invasive glaucoma surgeries, uh, in which I do bent ab interno needle goniectomy or BANG, excisional goniotomy with KTB glide, and the eye stent implant. The gold standard of surgery in glaucoma trabeculectomy and glaucoma drainage devices. I usually implant the AGV or the ACP. So indications of surgeries, uh, any glaucoma that is refractory to medical management, that is the target IOP is not met, and in spite of our medical management, progression is happening at a fast rate, then those patients need surgery. Glaucoma patients who are undergoing cataract surgery, who have significant cataract and need a cataract surgery, are patients that we uh, might include for a glaucoma surgery as a combined procedure. Any moderate, severe, or advanced glaucoma where the patient is non-compliant, is developing allergies to medications, medications are contraindicated, are or are unable to instill their eye drops, are candidates for surgery. So coming on to question of combined procedures, phaco alone or combined surgery. What are the factors that we need to uh, think about? First is the life expectancy. If there is a high life expectancy, a combined procedure would be preferable. Stage of the glaucoma, if visual field loss is advanced, then preferably I do a combined procedure. Target IOP, if it is not achieved, like we discussed, progression happening, again, a combined procedure, and glaucoma medications, uh, things that I uh, consider before planning the procedure is how many number of drops per day the patient is putting. The more uh, number of drops, the lesser compliant patients are, uh, allergies and contraindications. Now, which surgery has to be done? That's the second question that we get. Uh, Usually, the question is either minimally invasive or trabeculectomy. So, the most important factor that I consider before making my call is which stage of glaucoma the patient is. And that stage is dependent upon the visual field. If it's more of an advanced glaucoma or a severe stage, then I would prefer doing a trabeculectomy. In mild and moderate cases, MIGS would be my preference. The angle status, of course, open and closed angle. If there is extensive peripheral anterior A angle, surgeries will not work, and trabeculectomy would be a better choice. Again, the duration of surgery and life expectancies are something that I consider before I plan my procedure. So, minimally invasive glaucoma surgeries usually are patients with mild to moderate glaucomas who are undergoing cataract surgery. are very good candidates for MIGS, usually open angle patients. Let me skip this. Okay, now what are the contraindications? The contraindications would be the indications of filtration surgery. We'll discuss that. So these are the procedures that we do. The bent ab interno needle goniectomy, uh, where we take a 25 or a 27 gauge needle and bend it at the tip around 60 to 90 degrees. And under direct gonioscopy, we excise around 90 to 100 degrees of trabecular meshwork. It's a very simple, low cost, effective procedure. But bank procedure has a little bit more rates of complication, including hyphema and pus formation, as compared to the KDB Glide, which is a better instrument, specially made for this procedure. So again, under direct gonioscopy, you get a beautiful view of the angle, and with the KDB Glide, you see how much better, how much more precise, and how much more smoother the surgery is as compared to band. We excise the trabecular meshwork as much as we can see. It's usually 100 to 120 degrees. The only implant that is available in India right now for minimally invasive glaucoma surgeries is the iStent Inject W, where again we target the nasal and the inferonasal angle. It's a simple procedure where we go in and implant these trabecular bypass shunts or stents. A bit of blood regurgitation is a good sign that we are in the right plane. It's fairly simple 2-minute procedure that we can combine with the cataract surgery also, or as a standalone also, it works well. You see 2 implants in the trabecular meshwork. Now coming on to the gold standard, which is TRAB or trabeculectomy with mitomycin C. I'm going to, yeah. So this is the conjunctival peritomy, a bit of cautery, implying trabecular mitomycin C. I usually use 0.4 mg per ml for 1 minute and thoroughly wash with BSS. I make a triangular flap and trabeculectomy is completed with the Kelly sponge. PI is done and the flap is sutured. I place one releasable and 2 intermittent sutures. Conjunctiva is closed and the surgery is done. So what happens when the trab fails? We need to check if the trab is amenable to resuscitation. We can do bleb needling with antifibrotics, or if there is useful vision and the trab is not amenable to resuscitation, the other options are MIGS, retrab, or glaucoma drainage devices. Usually, glaucoma drainage devices is what we do. So the indications of drainage implants are 1 or more filtration surgeries that have failed, refractory infantile glaucomas, neovascular glaucomas, traumatic glaucomas. So all the dreaded glaucomas, the complicated glaucomas, usually we do a drainage implant. So this is the Ahmed ClearPath, which is a non-valved implant from New World Medical. Again, no financial disclosures. The advantage of this is that we can do it in a very small conjunctival peritomy. Usually 4 to 5 mm is what we require as compared to the 8 mm that we open up in AGV or in other implants. Because this is a non-valved implant, we make fenestrations on the tube and a suture is passed and ligated, the tube is ligated. Then you can fold the tube, the implant, and put it in through a small conjunctival opening. We suture the implant to the sclera, and a 23 gauge needle tract is made. The tube is implanted either in the anterior chamber or in the sulcus or in the vitreous cavity, depending upon the case. It is sutured to the sclera, and a scleral patch graft or a corneal patch graft is used. I usually use fibrin glue, which makes things easier. And we close the conjunctiva with interrupted sutures. That's all from my side. Thank you so much.